we will talk about physics of ionizing radiation and small definitions. Radiograph, this is an image. This is an image produced by transmission of the X-ray through an object. And as you might know, we use radiographs in medicine, in some technical specialties, and in a lot of fields on our everyday life. The radiography are the techniques in producing various radiographic images, and radiology is the science that interprets the radiographical images. Reminding ourselves the physics of the ionizing radiation, we do remember that the X-ray are on the right side of the electromagnetic spectra between the ultraviolet light and the gamma ray. The field that we can see, the waves that we can see, ends up with ultraviolet with 400 and 500 nanometers of the wavelength. And we don't see the X-ray, they're out of the visible part of the spectra. It has shorter wavelength than the visible spectra of the electromagnetic field. And an X-ray, it's an electromagnetic radiation. As we remember, from the right side, we have the increasing energy, and to the left, we've got the increasing wavelength. So once again, it's an X-ray, it's electromagnetic radiation. It's localized on the right side of the electromagnetic spectrum. And we have some notorious persons over here. First one is William Conrad Röntgen. He's got his Nobel Prize in Physics in 1901 for discovering and proposing the X-ray radiation. I'm sorry. Basically, the field that the medical implementation of using the X-ray was proposed a bit later. Sincerely speaking, from the beginning, it was like it was used much in entertainment. Antoine Henri Becquerel, he's got his Nobel Prize in Physics in 1903 to continue to develop the studying in the right side of the spectra in the X-rays, and Marie Skłodowska-Curie. She continued the studies. She's got 2 Nobel Prizes in 1903 and 1911. She discovered radium and polonium, 2 radioactive elements. And she continued the further developments together with her husband, with Pierre Curie, who's got his Nobel Prize in 1903. The wife and husband Curie continued the research. So why do we need radiographs? We need radiographs for primary, secondary assessment of the patient, or to help ourselves with the treatment plan. As you might remember, this is a paraclinical method of investigation. So this is not a primary. Method of investigation. It helps us in establishing diagnosis, but as I told you, it's secondary. It's not primary. And to do a treatment plan and review our treatment results, long-term results, and to assess the quality of the treatment done anteriorly. So which radiographical films do we use in dentistry? I'm sticking with the films, and I begin with the films, not with the digital sensor, because basically they are the same. They have the same function, the same role. Just that the film is an analog method of getting the image, and and the digital sensor is just a digital method, a digital manner. It has much more possibilities due to the fact that we could mathematically work with data to obtain the relative bone density and to compare to X-rays or a couple of methods of radiological investigation together to help ourselves, as I told, with the diagnostic treatment plan, comparing treatment results. So different sizes of films, all of them that I use in dentistry, they are standardized by size 0, 1, 2, 3, and 4. This is how a small X-ray apparatus looks like. With this is a digital one that uses an X-ray generator and a digital sensor that registers the X-rays that passed through an object. So this is so-called the lamp. This is the X-ray generator, has an anode and cathode. The anode is made from tungsten. The electronic beam from the cathode migrates to the tungsten anode and generates the X-ray. As you can see, they hit the anode, and then the X-ray is generated. One of the most challenging elements in intraoral X-ray is reproducibility. What does that mean? It means that we would like to have the same result in a couple of X-rays done in the same patient in the same region or in different patients. For that, there are a couple of elements that influence very much the result. And one is one of the key or the main elements in the technique of performing an intraoral X-ray is the trajectory of the X-rays that must be perpendicular to the sensor or to the film. And also they must be perpendicular to our field of interest. That's why we use some positioners, some special tools that helps us to respect this the position of the first, second, and third element. You can see them on the screen. Those are fixing on the X-ray generator and holding the film in place so that the axis, so they will be in the same axis. It's quite challenging to use them from the clinical point of view because, as you can understand, those occupy some volume in the patient's mouth. But at the time that you will be used with them, it will be much easier and no challenges you will have. Tomorrow we will be talking about radiation safety and safety control. I do remind you that we have to use special aprons to limit the field of exposure of the X-rays, because we would like to get the ray just in the region of interest that we are doing the investigation. We won't like something irradiated extra. So head and neck surgery, dentistry, which type of radiographs do we use? So we use extraoral and intraoral. We could divide them. Those are OPG and lateral cephalometry, posterior anterior view, and the intraoral are the bite wing, the occlusal radiographs, the periapical radiographs. So the extraoral are from the NBDA. In Moldova, we use some other types, a couple of more radiographs. I will show them a bit later. So each one of them, the bite wing radiograph, which are the indications? Those are used in regular dental checkups, proximal caries, the progression of a caries process, to look for the overhanging restorations and a diagnosis of periodontal disease. So this is a bite-wing radiograph. We can visualize very well the crowns of the tooth. We can visualize the superior third or fourth of the root and the alveolar process as well. And we can assess the smallest, the tiniest elements that I've mentioned a couple of moments before. The technique of doing this radiograph is patient biting the film holder together with the film, and the rays go perpendicular to the film, providing us the image that I showed. Periapical radiographs. Well, it's a bit different because we would like to assess the periapical tissue, the alveolar bone, the apex of the tooth. It allows us to do a good comparison between pre and post-treatment periapical condition. In those cases, the image should and will be deformed due to some peculiarities, anatomical peculiarities, especially in upper jaw. So before and after endodontic treatment, apical surgery, determining the presence of an absence or a dimension of apical cysts or developing of the granulous tissues. In dental periodontal trauma might be used, and assessing the root morphology before the extraction. In the difficult extractions, I prefer to use the cone beam computed tomography, and we will be talking about CBCT after tomorrow. So we've got a couple of techniques to do a periapical X-ray. The first one is paralleling film or paralleling technique, bisecting angle technique, and slope. I will explain each one to you. So the paralleling technique it means that the film should be placed parallel to the longest axis of the tooth that we're examining, of the root of the tooth, and parallel to the tube, to the X-ray generator, and the rays should be perpendicular 90 degrees. In these situations, we must use the film holder that I showed you previously, and as I told you, it's quite challenging due to the fact that it occupies space in patient's oral cavity. And that's why sometimes in pediatric patients, it's very difficult to work and to manipulate with a film holder. Which are the advantages? We have a relatively high accuracy, geometrical and dimensional accuracy, I mean. And it is considered to be free of distortion if those rules about one parallel to another is respected. It's very simple to use, and it can be, and the reproducibility is very high. We can standardize this method of investigation to compare the evolution in the same patient, or to do research to assess one or another method of treatment in different patients. The disadvantages is the film placement, as I told you, requires to have a film holder. In pediatric patients, we've got some challenges. In some cases, as I told you, on superior jaw, the anatomy makes those things pretty challenging due to the shallow palate. In the third molar region, it's practically impossible to do, and it gives discomfort to the patient, the positioner itself. The bisecting angle, as I told you, due to the anatomical challenges and anatomical issues, in some situations we would like to neglect the rule of everything has to be parallel due to an impossibility of getting a periapical image using this method. That's why we would like to shift sometimes the angles. We would like to change the angles and the position of the film. So they won't be parallel at this time. Um, the angle will be changed. Um, the film is placed as close to the tooth as possible, so we don't have a long axis of the tooth and film parallelism respected. And the tube should be installed perpendicular, the rays should go perpendicular to the film. This techniques helps us to use the film without using any holder. It's comfortable for the patient and less time is required to do so. The disadvantage is that we will have image distortion and magnification because the parallelism is not respected. So it's technique sensitive. Sometimes when the film or the sensor was not positioned correctly, it takes some retakes. It's not reproducible, and in some cases we will have another type of anatomical challenges as well as in those situations, like the zygomatic buttress and over the upper molars, the external oblique line. And another technique is slope, same lingual, opposite buccal. Usually it is used in the mandibular molars due to the fact that the root canals are superimposed if we will have everything parallel and everything perpendicular. We would like to assess the retained roots and erupted teeth, some different foreign bodies that are localized in that region. This method have a lot of synonyms. You see them on the screen now, and how it's done. You can see the image in the upper part of the screen that gives us understanding about how works the classical method. For instance, we would like to use the positioner, and with the positioner, we've got the root canal superimposed, but we would like to assess all of them. In this case, we will have to shift the beam position to the left or to the right to avoid the superimposition and to permit ourselves to have an adequate assessment of both roots. So this is how it's done. The shift is usually 20 to 40 degrees, depending on the anatomy of the patient. So you can see it on the right, on the upper side, and on the lower side, the projection and deprojection of the root canals. And the occlusal radiographs. The occlusal radiographs do permit us detecting the presence of some unerupted tooth, supernumeraries, odontomes, different other types of cystic formations, buccolingual relationships on the objects, different cysts and tumors, fractures, and determining stones in Wharton duct. In our country, this was probably the base before the cone beam computed tomography and multispiral computed tomography appeared. This was one of the main methods of determining the stones into the Wharton duct and in some cases into the salivary glands. You can see right now. The patient is asked to bite the film, and the cone is placed inferiorly to the perpendicular to the direction of the film to assess the presence of some stones, which you can see on the upper right corner. The same thing could be done in maxilla. It's a little bit more challenging because we have some bony anatomy that overlaps in some cases, like the nose, and you can see the scheme on the lower left corner of the screen. And this is just to remind